Now, our final speaker in this session, to screen or not to screen, is Dr. Hoenderkemp, who is a GP specialising in women's health, and she will talk about giving women a choice.
Thank you very much. Okay, is my presentation on here? Hello everybody, and thank you for the opportunity to chat to you today. As Kirsty said, my name is Dr. Hoenderkemp, but Hoenderkemp is such a ridiculous name that from the moment I qualified as a doctor, patients naturally called me Dr. Rene, so that really is how I'm known now in almost everything that I do. So today I'm going to talk to you about breast screening from a GP's perspective, and I actually, because I didn't read my emails properly, thought I was going to talk to you about my go-to topic, menopause, but the lovely Louise Newson's going to do that. So I learnt lots today because I had to think about something that we don't think about very often as a GP, and that's what I'm going to cover today, and it's actually really interesting. There is a dilemma for GPs and breast screening. So firstly about me, I'm an NHS GP. I'm the BBC Radio London resident GP, and I have a monthly show there where we take any listeners' callings, whatever they're thinking about, so that can be breast screening, absolutely anything. I'm the Daily and Sunday Express resident GP online, so again answering just questions, and the same for OK Magazine. And as Katie said earlier, the resident GP for the Latte Lounge, which has been fascinating and interesting and all-consuming at points. I have a YouTube channel where I cover every possible topic in detail, in patients' language, so that they have a resource to go to, just to understand things that they just don't generally get to talk to their GPs about because of time, and I'll come on to that. And I'm also mum to this little munchkin. And she's here today. And why is this relevant? Well, I'm 51 and she's 11 weeks old. And I obviously want to be around to see her go to university. So for me, screening of any sort that can help me prolong life and make sure I'm here for Alice is really, really important. And I'm a big advocate of screening for my patients, but I'm also a big, big advocate of them understanding what that screening involves and what the benefits and the risks are. And this is where the dilemma for me comes in as a GP. Being a GP in 2018 is a miserable job at times because we are constantly criticised by just about everyone, by the press, by NHS England themselves, and by patients. And they tell us that we're only in it for the money. I wish that were the case. That we don't have time for them, and to some degree we don't now because we're forced to have 10-minute appointments. That we, as women, ruin the NHS because we go off and have babies. I had one at 21 and one at 51, so I guess they're right. And that we just do paperwork, and there is a lot of paperwork. So as a GP, we are under pressure all of the time from every direction. But then at the end of all of that criticism, we're told that we just don't care about our patients anymore because we don't get up at 3 o'clock in the morning and dash off and help them deliver a calf or something and also sort out their ills. But, you know, that's probably the most maddening thing that anyone ever says to me, because I can tell you that every doctor in this room is in it because they care about patients. And that's why we became doctors. And even though the pressures are there that try and stop us caring about patients, we do. And we have sleepless nights. And we go the extra mile to make sure that we're doing the right thing for our patients. And sometimes it goes wrong, but not deliberately. It goes wrong because things do go wrong. But most of the time it goes terribly right, and we do the right thing by our patients. So what's the dilemma for GPs and breast screening? Well, firstly, we do fear, as Michael said, breast cancer. It's the biggest killer of women in terms of cancer. So it's really important. 31% of cancers in women are breast cancer. So what's my role in this screening process? Well, to be honest with you, now I sat back to think about this presentation, I don't have one. And that's outrageous, really, if you think about it, because I have a massive role when it comes to other screening programmes, like cervical screening, because we do the cervical screening. So we chase patients. We constantly get reminders on our screen. Mrs. Jones needs her screening. When there's a patient there, we remind them, we cajole them, we get them to come in for cervical screening. Although hopefully in 30 years' time we won't need it anymore because of the vaccine. But breast screening is a standalone service. We don't get involved. We don't cajole our women. We don't chase them. We don't get reminders on our screen that Mrs. Jones needs her mammogram. So she just gets a letter in the post, nothing to do with me. I don't know if she's got that letter. I don't know if she's gone. I do know if she's gone and she's got breast cancer because I will eventually get a letter and then I will be involved in her aftercare. But that's all a bit late really, isn't it? You know, shutting the door after that horse has definitely bolted. So the only patients I see about their breasts are ones that self-present. So they come to me because they've found a lump, or they come to me because they're worried. They're worried about something they've read in the press, or they're worried about a family history and have they got a gene. So then we do get opportunities to sit down, examine them, talk to them. Of course, if we examine them and they have a lump, and actually if they think they've got a lump, even if we can't feel it, we refer them into the screening process. So we do have very, very limited opportunity to counsel patients, and I think that's the real dilemma here. So counselling is crucial, especially in this day and age where we are talking about patient's choice. That everything a patient does should be their choice, with their doctor having armed them with all of the information they need to help them make that choice. And we do that, as I've said, for cervical and bowel cancer screening. We tell patients the benefits and the risks because it's important that they know this. In fact, it's not just important, it's a duty. We've seen over the last few years with the Montgomery ruling over a woman who gave birth to a big baby who unfortunately was brain damaged because they got struck by their shoulders, that we have to tell the patients every single risk, however low the chances are that it might happen. Because if it's 1 in 100,000, when it happens to that woman, it's 100%. So we have to tell them every single risk as well as the benefits. And that's, I think, where a GP should come in. We should be involved in the process and we should be talking to women about the screening process. I'm not standing here saying women shouldn't or should have mammograms. I'm saying that I should be able to talk to them about it, what their risks are and whether or not it's right for them once they've weighed up the risks that I tell them. And we know what they are. So this figure is controversial because it obviously marries with Professor Howe's figure of one life saved for every 200 screened. But there are other figures that suggest that it might be much lower than that. And we've seen with Michael's presentation that it could be 1 in 100,000. But this is the figure that the NHS present at the moment to patients. It's on their website. So it's the one I've included in this presentation. But it's complex. As Michael says, it's really complex. And stats are always complex. And describing them to patients is even more so. Actually getting a patient to understand the risk of anything is really hard. You know, if you got on a plane and someone said there's a 1 in 200 chance that this plane might crash, most people might get off. You know, so it's really hard to put it into terms that mean something to a woman or a man, depending on what we're talking about, that's real. We do know that when cancer is detected by breast screening, that there's less need for surgery, less chance of mastectomy, and less need for chemotherapy. So when we are detecting them, there are benefits, and these are the benefits. But there are some risks as well. So some women are diagnosed and treated for a cancer that would never have actually caused them harm. And the figures there are probably 3 women in every 200. So that's 4,000 women a year undergoing stress, invasive treatment, and actually they didn't need it. For every 1 woman whose life is saved, 3 are diagnosed and treated unnecessarily. Now you might say, well, that's a life saved versus 3 treatments unnecessarily, and that's fine. This is what it's about. It's about each individual person weighing up that risk and deciding what to do. 1 in 25 women will be called back from their first screening, and that is terribly stressful. And that is sometimes when we go see them because they're so worried about the chance of having breast cancer. And that's a lot of women when actually most of them will not have breast cancer. In fact, 1 in 4 will actually have a cancer of any description. And there's a lot of false negatives as well. So there are women who are being screened and being told they're fine and being given that false reassurance. It's 1 in 2,500, which I think is a fairly high number. And then, of course, there's X-rays. We've seen that radiation is never risk-free. And it isn't risk-free. If it was, everybody would just do it willy-nilly. But we always think about radiation. In fact, that's the law now. There's a European directive that we have to consider the radiation we're giving to a patient and make sure it's the maximum that they need. So there are risks and there are benefits. The way I see it, my role is to care enough And I do care enough, and I believe that 99% of my GP colleagues all care enough too. I need to arm patients with all of the information, give them time, and that might mean giving them the information and calling them back. And I quite often do that with the menopause because it's such a big topic and there's so much. I quite often give them some homework, send them on their way, let them watch a vlog and read some stuff, and then come back when they've had time to digest it. And that's probably, there's Alice, that's probably the way that we should be doing things. You know, when we do informed consent, the GMC says that the patient should always go away and have time to think about anything we do before they make a decision. And I also think we need to be educating young women from school age to examine their own breasts, because nobody knows their own breasts if they examine them properly like they do. So it's about education as well, and making sure that we give women every possible tool to catch things early if they can, and to understand the screening process and make an informed decision. And that's my dilemma. I should be allowed to be part of that process, and we're not part of it, and we should be part of it. There is good and bad in everything we do as doctors. That's my take-home message. So women just deserve to know what they're letting themselves in for before they leap, and it might be brilliant for them, and that's fine. But just let them know and give them someone with the knowledge and expertise to help them through that. Thank you very much.
Right, well, I think we can, I know that you're all dying to ask questions, so I'd like to ask all the speakers back to the stage. Hands up. Lady at the back in the pink jumper. Have we got a roving microphone, or do they just...
There is a roving microphone at the back, on the stand. It's not roving at the moment. Someone could rove it for us.
Put it on a roving human.
Oh, well, you might as well take it. Look, it's there you are.
We need to use the mic because it's being recorded.
Oh, it's being recorded, yes, so we
Okay.
need it. Yes, go ahead.
Well, okay, I'll use the microphone then. So, my first thing I wanted to say is that breast cancer is still the #1 killer of women between the ages of 39 and 55. So to say that, well, I mean, with all the good news stories, actually that is still a fact. I think 2017 was the release of that information, or that information is dating from 2017. I had a question for Mr. Baum, really, that he didn't have any figures for late-stage breast cancer. There weren't any figures for metastatic disease in your comparisons, and I wondered if you had anything to say about that.
Yeah. Can you hear me? Yeah. In the limited time available, I wasn't able to give everything, but your question is very apposite. I could have showed you a number of papers published in JAMA, Journal of the American Medical Association, and the New England Journal of Medicine, which plots those graphs. I showed you, and I didn't have time, I showed you one graph, I didn't have time to deal with it. There is incidence of DCIS going up like that, incidence of early invasive cancer going up like that, incidence of advanced metastatic breast cancer flat. There is a small improvement in the incidence of the localized but more advanced cases. But as far as metastatic disease, I can give you the references, but Gilbert Welch in the New England Journal of Medicine is one. And if you email me, I'm always happy. See, another thing about dealing with lay people, you treat them as adults. If they're really interested, you send them the papers.
I'll definitely email you. In the UK, our stats aren't gathered. They don't know actually how many women there are living in the UK with metastatic breast cancer at the moment. I have metastatic breast cancer. I'm 36, so that's something that concerns me.
Absolutely. You see, I think your group are underserved. Tony and I agree. We're so obsessed with preventing the disease, catching it early. we don't realise that there's a very large cohort like you who are not really... would you agree with me, Tony, about the research that's going on?
I agree entirely. May I make a comment? And that is that you are underserved, and what we want to do is to have probably between 30 and 35 have a clinic where you have your density done, you have your those things that I mentioned, there's a saliva test done, and you have a very low dose mammogram. We need to investigate that in order to see how we can pick up, if I may say, women like yourself. And that is going to take a long time. But we have not done it so far, and we are now beginning to address it, which may please you or may not, because it's after the event.
It wouldn't have helped me anyway. I self-referred. I was treated for my primary, and then a year later I had metastatic anyway. So treatment doesn't always cure. And I think the other thing to say around that really is that I kind of agree with what you were sort of touching around the edges of, actually, that breast cancer doesn't follow a mathematical model. There are lots of women who potentially develop metastases before there is anything detectable happening in the breast. Does anyone else have?
Thank you very much.
It happens.
Yeah. Thank you very much. Could we move the mic up to the front?
I just wanted to comment on a very important point I felt which Professor Baum brought out, which is relative risk, because this is quoted in every single newspaper we see, not just relating to screening and prevention, but also to treatment, and it is so misleading. The problem with relative risk is it's relative to the original risk, hence the name. And everybody, when they think of risk, they think of actual risk. And the problem is if your original risk is low, for instance, if your risk of getting breast cancer is low, then your relative risk appears falsely high. And people who understand that are nodding their head vigorously, but the problem is this is very misleading to patients. And as I say, not just for breast cancer screening and the benefit of breast cancer screening, but also treatments, for example, anti-estrogens, which are used a lot. If your risk of recurrence is, say, 5%, and the improvement is 20%, it sounds like this is massive improvement, but actually it's only reducing the problem from 5% to 4%. Whereas if your original risk is very high, say 50%, for example, for the maths, then you're reducing it to 40%, which is a big difference. And I think this is a message that's so important to get across, educating people, going back to what Professor Baum and Professor Howell are both saying, that patients need to be able to make their own decisions, but they need to understand the information they're given. I mean, I'm a doctor and I had breast cancer, and I'm actually in research and I've written a book to help people. But even when I was being told the relative risk, because I was in a state of shock, even I was getting confused. So, how can people make rational decisions when they really don't understand the information that they're given?
That is a fundamental point you've made, and I'm delighted. It allows me to go on a little more. First of all, I want to give you a hypothetical explanation for relative risk and a real issue that's cropped up already using relative risk. You're in Uzbekistan, you want to fly to New York, and you have two choices, Air Uzbekistan or American Airlines. You learn that Air Uzbekistan crashes twice as much as American Airlines. And you could save yourself $500 on Air Uzbekistan, but you're not going to risk that. In absolute terms, say Air Uzbekistan crashes 1 in a million and American Airlines 1 in 2 million, there's a 1 in a million chance of that happening, and $500 may be worth that risk. So, I mean, that's a comical way, but it does explain. Now, what's cropped up in these discussions, you've had two explanations about the mastectomy rates in screen-detected cases, and they seem to be contradictory. I've said mastectomy rates go up. Tony says mastectomy rates go down. Renee says mastectomy. And the problem is all to do with relative risk. In relative terms, the mastectomy rates go down in screen-detected cancers. In absolute terms for the community, it goes up. I showed you the increase that Michael Drake and I published. There is an increase in mastectomy rate in absolute terms for the community, and that's because mainly the overdiagnosis of DCIS, which is often multifocal. So that's the fundamental point in these discussions.
I never use relative risk. It's crazy. You don't understand.
I agree. I mean, it's fabulous for statistics, which is what it's intended for.
For example, in the risk clinic, I say, do you want to know the risk that you have for the rest of your life to 85? Well, our information indicates that your chance is 1 in 4 chance, not relative to anything else, your chance. So if there are 4 of you, 1 will get breast cancer and 3 won't. That's the sort of thing to say. Some women, not many, and I showed you 10-year risks on one of my slides, they can ask for a 10-year risk. What's my chance of getting a cancer in the next 10 years? At even high risk is 1 in 100. It's not very high in 10-year intervals. That's more difficult to understand. So we found, in general, and I'm only talking about the risk clinic at the moment, you can think of other things. In general, we've published on this, and relative risk is barely understood. This business of 1 in something seems to be understood, because we've then published another paper saying those women seem to remember it better than ones giving it in a different way.
I think that's great. I think the only problem is that it's used scientifically quite validly, and of course that's what often gets quoted, particularly in the media, by people who don't have your understanding, and that's...
Renee, and then...
I think you make a really, really important point, and I think it comes back to what I've said, is that we need more than one contact with a woman before she goes for screening, or even when she's had a diagnosis, because as you said, you didn't take anything in.
Yes.
And so having that time to just sit with someone and talk them through it, and then bring them back when they've had time to think about it, write down questions, discuss it with family members, is crucial. And then the understanding might, develop from there, because the relationship helps as well that you have with the GP, and also the time.
Renee, can I just ask a follow-up to the triage process that was being suggested? Is that something that GPs would take on, do you think?
I think the answer to that is no. I think it would probably be too complex.
To a certain extent, you do it already. I mean, if a lady comes to do, she's at risk for a family history, you'll refer her through to a clinic.
So if she comes with a family history, or she comes with a lump or something like that, we would refer. But I think if you're going to talk about it as a population, then probably it would be done by a screening centre.
And it seems, on that point, presumably, if we were to go ahead with the triage system, it would save huge amounts of money. It must be attractive to the politicians, isn't it?
You see, my futuristic look is the risk assessments will be done by the women on is programmed. In fact, we can already do it.
It's being done.
It's being done.
It's the question of whether GPs have time to do it.
Well, I guess then, we do for heart disease now, we have things like QRIS and brain temp.
Exactly.
So if it's a simple programme where we put in stats and family history and things like that, then yes, then it would get done at GP level. And
so
that would be very useful.
That's being introduced as we speak into general practice, and that would fit in with what you're saying. And the other thing is that doing it on a population level is a bit more difficult, because you're looking for other risks than just family history. Only about 12% of women have a first-degree family history, but more than 12% are at risk of breast cancer. And not always 12% of the family history of risk of breast cancer. Very complicated. But there are other measures, as I mentioned in my later slides. The risk-associated common genetic changes are one of the most powerful risk factors for breast cancer. Now the question then is, how do you introduce that on a population level as you suggest, Michael. And the other thing is, as I've told you, another major factor is mammographic density. How do you introduce that on a population basis? So these things actually are fascinating, and they're there to be introduced in collaboration with people in tertiary care, secondary care, and in primary care in general practice.
There's a question here.
I'd like to make a comment and ask a question about diet and lifestyle. I submitted inputs to NICE. I made 16 specific submissions to NICE about diet and lifestyle, and they threw them all out because I think NICE cannot cope with diet and lifestyle. So I'd like to ask people here, hands up, do you think diet and lifestyle plays a part in cancer? Well, NICE and many in the medical profession don't understand the problem. That's all I'm going to say about it. Do you think it does?
It's clearly crucially important, and as everybody says, if you lose 5% of body weight and you exercise, you might reduce your risk of breast cancer by about a quarter. And that needs to be out there. One of the ways that we do this in our risk clinic, women have lifestyle advice from dietitians, because it's very difficult, as you know. You can give advice, but it's only accepted if you follow up with something. And all the papers say that. So what we're trying to do now is to consider introducing that into the screening program. So we've got a program on at the moment of investigating whether you can give lifestyle advice in the screening program. The answer is you can.
Just to address that question, personally I do think so, but there's a caution in saying that. The problem with all these epidemiological studies is they are associations. So yes, there's an association with not exercising, not having a diet, not doing this. But that doesn't necessarily mean causation, because there are so many confounding variables. A woman who drinks too much wine, quote unquote, I don't think there is such thing, but that's said to increase the risk of breast cancer, but it is associated with an increase, and a woman who drinks too much wine does lots of other things that is linked to the drinking of too much wine. So it's hideously complex, but at least with drinking wine we have a biological mechanism. Well, most of the other things, there is no obvious biological mechanism.
Yes?
There's only there are two randomized trials.
Yeah.
One in women who develop breast cancer, showing that if they lose weight, they have a reduction of relapse, and that's out there. Paper by Ron Shabowski, you should look it up. And then there was the Women's Health Initiative, and the Americans had an obsession with saturated fat. So those women in that big study randomized between having a diet and not having a diet in 30,000, 40,000 women, I can't remember the number. There was a reduction in risk of breast cancer in those, not whether they complied with the fat, but whether they lost weight or no. A relatively small proportion lost weight in that randomized trial in the intervention arm, and they had a decreased risk of breast cancer. Those are the two bits of randomized evidence, which are obviously the strongest that we have. And then there are other important epidemiological studies that Michael mentioned.
Renee?
Just to pick up on that, I'm actually a NICE committee member on another guideline, and the problem for NICE and people sitting on the committee is that the standards for evidence are so high that almost nothing is admitted on any guideline. It's really hard. They have to be gold standard, randomised controlled trials, big enough. You know, it's really, really difficult.
So basically there just aren't enough trials concerning diet and exercise, and if there were. There's a lady in a stripy shirt first, and then I'll come to
Hello, 2 points, if I may, please. And I'll just say that I'm a retired barrister, and my expertise, such as it was, medico-legal, and I edit the medico-legal journal still. The first point that occurs to me, having talked about weight and weight reduction, is that we are currently experiencing a huge rise in obesity, and I do wonder whether any of that has been taken into account, whether this hugely, well, unfortunately, heavier population, whether that has made an impact on any of your stats. But the second point, which is really more up my own street, is that it is a huge cost to the health service, to the taxpayer, to pay for unnecessary procedures, and it goes far beyond that. What happens when somebody has unnecessary interventions, put it as lightly as that? They come off work if they're working. They can't necessarily look after themselves, so somebody has to stop work to look after them or their family. They can often become depressed, and they may stay off work for quite a long time. And all this adds up, and then they may suffer some severe injury and may be unable to work at all. And this is not really put into the equation. The cost of the collateral damage is huge. Yes. And I just wonder how much you could reduce the costs for the health service and perhaps divert them somewhere more useful if you reduce screening to those for whom it's really appropriate. If you were therefore you would reduce the number of inappropriate interventions, and whether this has been costed out and whether it should be. Thank you.
Thank you.
Kirsten. She's been desperately trying to...
Oh, sorry. Yes.
Do you want to answer that question?
Oh, that was the question you were going to...
Do you want to answer that question first, and then I'll answer?
I think
Sorry, Katie, I didn't realise. I thought you were gesturing at the camera.
there is a very strong piece of data, mainly to do with weight gain between the ages of 20 and 50, which is very common. But if you gain 2 or 3 stones in weight, you nearly double your risk of breast cancer from whatever your risk of breast cancer was. So you need to estimate that in the first place. But say you have a 1 in 3, a 1 in 8 chance of breast cancer during your lifetime, which is about the standard risk. If you're obese, that may go as high as 1 in 5 or 1 in 4 lifetime risk of breast cancer. So it's a serious problem based on those calculations from epidemiological data.
So we've got a question from our group from Tara Gould. She's saying, I've had 2 private mammograms over the last 5 years, which showed a few lumps of fatty tissue. It was recommended I go for ultrasound, which I never did. I've now been called for my NHS mammogram on Friday. Should I go? What if something else has appeared and I'm none the wiser?
Tara, it's as we said in the presentations, all we can do is give you the risks and the benefits, and the decision has to be yours. You know, how you feel about the benefits which are there and how you feel about those risks. And I'm more than happy, I know Tara, obviously from the group, I'm more than happy to talk to her about it later, but I think it has to be a personal decision. Looking at her family history, how worried she is about breast cancer, what she thinks her risks are, and then weighing up the harm that could be caused or the good that could be caused.
Thank you. Can I ask one more
Yes.
question from the group? Because I'm here on sort of behalf of the average woman on the street,
That's about you.
That's about me, sums me up. But the problem we have is it all sounds scientifically fascinating if you understand what you're talking about. I just about do because I'm your daughter and I've grown up hearing this most Friday nights. But most women, they get that letter through the door and it says come for your screening. They don't give it a minute's thought. They book their appointment and they go. And that's it. They don't even read what's in the leaflet.
Yeah. So this is it. This is the whole point, that they're handed this letter alone. Nobody's guiding them. Nobody's discussing it with them. And I'm sure when they get to screening, nobody sits down and talks through the risks at all. I've had the screening. I'm absolutely sure of that. So this is why I think GPs need to have a role. And, you know, we're already overworked, so GPs will be screaming at me across the country saying we don't have time for this. But we should, because it's a really, really important issue. And that's where the woman should come with her letter and say, talk me through it.
And then the pros and cons of a Facebook group where you've got this massive community of women just saying, "Oh, do it. You have to do it. Why wouldn't you do it?" And that's half. You know, the battle is in the background. I can see there's a lot of bad advice and also some really good advice being given. Yeah. But you know, the most common thing is, well, why wouldn't you? Yeah. You don't. If you break a leg, you go for an X-ray. Why wouldn't you? You know, go for screening.
The other thing is, a group of us for the last nearly 20 years have been trying to do something about the leaflet of invitation, because that leaflet of invitation is coercive.
Yes.
Mummy knows best. And sending an
was coercive.
What?
It was coercive.
Yes.
You've changed it.
But it still is because
we've managed to change it. It's less coercive. But what we've been trying to do is not send the appointment, because sending them the leaflet and sending them an appointment, we still think it's coercive.
So, but what's the advice, though, would you say, for a woman now? So you get the letter. Is the advice you'd give her is to go to the GP and say, how high is my risk? Is it worth me going? Would you then go through the risk factors? I mean, my cancer was caught through routine screening, but I've got breast cancer in my family. I've got a history of it.
Yeah.
I'm an ex-smoker and so on. So presumably I would have ticked a lot of boxes anyway, and you would have said go ahead with the screening.
Or given, you know, your chances are obviously a little bit higher because of your family history. Therefore, when you're looking at these stats, you know, we can view it in a different way. It's the role of the GP. I see women all the time who don't want to have their cervical smear. And I talk them through it. I talk them through the benefits, the harms, and there aren't really many, you know, and that's an easy one to do. And I think that's the GP's fundamental role, that when a patient is confused and they don't understand, you know, the information and their risk, they should have somebody of a medical ilk to talk it through with them.
So if you went to your GP and said, I've got a family history, she or he would send you to a clinic to deal with that. They would estimate your risk, tell you your risk, and then say, well, what do you want to do about it? And you may have increased screening, you may have tamoxifen, you may have, if you're very high risk, as Michael said, we do genetics in our clinic, and I saw a lady actually from Vladivostok on Thursday, and she'd been in England for some time, but it just seemed greater coming from Vladivostok. But she had a gene test, and she had a BRCA2 mutation. She also had what's called BIRADS4 mammographic density, very high mammographic density. When you put those two together, her risk of breast cancer came to about 95%. This is the sort of person that Michael's talking about. And she almost certainly will go for risk-reducing surgery. Not only to her breast, but she's at risk of ovarian cancer as well. So there is a huge service out there. There's the genetic service, the service that we give. But there are others out there that are not family history, but at risk of breast cancer. And those are the ones that we need to think how to do it.
Question here.
Hello, I'm a mammographer in the breast screening programme, so I see a lot of ladies who come for breast screening for the very first time. This isn't my question, but I'm going to pick up on what you said. We had 5-minute appointments. We cannot cancel a woman before we go ahead for the mammogram, but we do discuss the leaflet, ask them if they've read it, and a lot of women don't. You can send the information, but they don't read it.
Exactly. It's not a criticism of the system, it's the time that you have.
It's the time allocation. Now, going back to what I was going to ask, first of all, was that you've mentioned about women in low risk don't need to have breast screening. Maybe, and you're looking at this. How complex would that be to put out to the whole population? Also, if you get somebody in that low risk group who gets breast cancer, has breast cancer, and they haven't been invited to screening, the litigation gate just opens up. And how would that be addressed?
Absolutely right. And therefore, in the first instance, you must get bored with me saying you have to do a randomized trial, and that's what we're doing, to see what the benefits and the harms of that approach are compared with women who are having your standard in the NHS.
Can I respond to that? We naturally are fixated on breast cancer. What I was trying to get across, there's more to death than breast cancer. Only 1 in 25 women will die of breast cancer. And these low-risk women are, in other words, 25 times more likely to die of cardiovascular disease. So our responsibility, the GP's responsibility, is to... You already do cardiovascular.
We do.
Yes.
Yeah.
So this again comes back to the GP, who should be allowed the opportunity to balance out all the benefits and risks. And I can tell you already, from what I've heard this morning, forgetting what you and I said, but in fact, remembering what you've said, we've unearthed a serious problem which is not being addressed. And that's what I wanted. Having lay audiences and with GPs, this is the forum for change. We can make stuff happen. And there are journalists here. And Woman's Hour is interested, and the Daily Mail is interested. We can make stuff happen, yeah, sure. Only because we are a different group to the usual dichotomy between us scientists and you, the lay people.
There's a question here, and then I'll come to you at the back afterwards.
As a GP, I just wanted to stick up for GPs because it's actually, as Rennie knows, it's really hard, and it's a lot harder. The last 15 years has become almost impossible. So some GPs have one problem, one consultation, 5-minute appointments sometimes, book on the day. It's really hard. I really respect Tony. I've known him for a long time, and I would love to work near at Manchester. I would love to refer my patients to him and get this really good, dedicated, high risk, find those women, which is really important. I live near Birmingham. I refer to Birmingham. Our patients get turned away because they're not high enough risk on the NODI scale scoring that we do. So I agree someone should do it, but I'm not sure GPs. Actually, nurses are so much better than doctors at going through tick boxes and giving time for patients. They're actually more empathic often than doctors. So I think there should be someone, and some of the money that can be saved by unnecessary screening, maybe in low-risk women, could be used to educate a healthcare professional or a lay person to talk about risk, because actually most of my colleagues know nothing about risk with breast cancer.
Maybe it doesn't happen in the West Midlands, but around the country there are clinics for high risk, as you know, and a large proportion of them are manned. Man is not the right word. They are nurses.
So in primary care it should be the same.
Staffed. Can we take the mic, move the microphone to the back, and then I think this will be the last. Well, we'll try and squeeze in one more before the coffee break. Yeah.
Thank you. I'm actually speaking of someone who had early-stage breast cancer, and as Professor Baum knows, I went to Italy for interrupted radiotherapy. Now, my thinking, and I'm not sure whether my logic is right on this, given that I was diagnosed with cancer, and then if we're attacking the linear model, there's no saying that my minute cancer, 2-millimeter tumour, would have developed into a bigger tumour and with a risk of metatasing. Could this model be used to, given that there's an argument that people are over-treated, could the argument be used to enable someone to refuse treatment? I don't know, I may have been treated unnecessarily. I mean, in actual fact, I'm glad that I was treated, and that was discovered from a routine mammogram at Birmingham Women's Hospital.
I predict that Professor Videa will answer that question. It's a very important question. I know what Professor Videa is going to say this afternoon. He'll give you the long answer.
And there's just another question there over the aisle. Do you still want we can squeeze that in?
Yeah, strangely, it's actually related, which is interesting, because my question is about, you're talking about the coercion of getting the invitation. What happens, and happened to me, was that when I was diagnosed with having the in situ tumour, was that I was on a conveyor belt immediately And what I had to fight, and I don't think a lot of people do fight, was there was a 30-day target for me to have the operation done by. And that is daunting, because to actually say, hold on a minute, there's aspects around this I want to understand more, takes a certain type of person. And I was also surrounded with family and friends who were all just doing the, have it taken out, have it taken out. And it was only because I did the research with Uncle Google and that I came across the IORT as well, and I'm very glad I did. But I had to really push to be treated as an individual rather than as a statistic.
Well, I think we're going to discuss that this afternoon, but I agree with you, because I was in exactly the same situation, and I opted for IORT, but I was told absolutely not to have it by
I was told it didn't exist.
So,
I was told it didn't exist.
I think we've got a couple more minutes, so one more question here. Yes.
Nathan Coombs, one of the surgeons in Swindon. I just want to pick up on that point. Once people are diagnosed, this conveyor belt actually isn't just for the patients. The hospitals themselves face penalties if you don't see a patient within 14 days, treat the patient within 62 days of the initial letter, 31 days of diagnosis. That doesn't give enough time for the patient to even go back to the GP to unpackage whether they want investigations, what those investigations mean, and then when you do get a diagnosis, the time to spend unpackaging what the best treatment for that individual might be, rather than a one-size-fits-all. And I think sometimes targets do more harm than good. I said that at a consultant interview and I didn't get the job. And I'm glad I didn't. But I think sometimes this, again, you're so focused on trying to treat people, whereas actually the patient's tumour has probably been there for 6 months or longer and probably isn't going to do very much in 31 days or 32 days. So actually, maybe patients need to be stronger to say, okay, 31 days, I'd much rather make my decision and go to 35 days and have the right decision for me, rather than having a pre-packaged programme of care. How do we get that message across to our patients?
Yeah.
Dear Mrs. May.
Yeah. I think, okay, one very, very final question, then we're going to wrap for coffee.
Just picking up on dear Mrs. May one, if we are going to change attitudes, what are the right political pressure points to press?
They're relatively, well, to me, you can see I'm fairly simplistic. If you have evidence for benefit, then with sufficient push, you can get that introduced. Michael's done this all his life. For example, the randomized trial of tamoxifen versus placebo. Did you have a placebo?
No.
No, it was pre-placebo days. Shows how
pre-placebo days.
How old Michael is.
But informed consent.
Yeah, absolutely. But the trial showed that tamoxifen reduced relapse rates by half, and that then, you know, you're on a roll. And so if you produce evidence like Michael has done, we did a trial of anastrozole versus placebo for prevention of breast cancer. It cut down breast cancer by 50%. NICE had already looked at and brought in tamoxifen for prevention, and they looked again 4 years later, because the evidence, you know, the data from the trial were quite strong, very little toxicity, and a lot of benefit. That's what they said. So you've got an open door if you've got good data.
Final point from Renee.
I do think that in our current climate, probably the push point is always money. So if we could demonstrate that by doing things slightly differently, less people would come to harm, and in doing so money would be saved, that always talks. And I think that's sad that that's where we are, but I think in our current economy and health economy in particular,
I've got the experience.
It's really important.
Yeah.
I want to bring Jay in here.
Two points. One about lifestyle and the randomized trial which you mentioned. The only message I took from the randomized trial was that women who were randomized to have more fruits, vegetables, nuts, and less than 20% fat in diet were found to have less not less breast cancer incidence, not less breast cancer deaths, but less deaths after breast cancer. So there could be other compounding factors that could be leading to that. The other point is that data alone, unfortunately, although that's how I've grown up and that's how I still believe, is not enough to change practice. And economy is paradoxically
Data and reduced costs.
Yeah.
No.
Reduced cost was other way around.
No.
Yes, because there are sometimes entrenched interests within parts of the health service that... Go ahead.
No. I agree. Sorry, I agree we need data, and I agree we need money. But I'm in my mid-80s now. I've been fighting for 30, 40 years to get things changed. It's exhausting. I've run out of energy, and shifting the convention, persuading politicians that they're doing is a hiding to nothing. It kills you, it wears you down. And never mind the data, never mind the fact you save money. The push has got to come from you, the women. If you want to change, I'm really passionate about this. This is why we call this meeting. If you want to change in ways we've heard, you've got to take the lead. It's got to come from the consumer advocates. You've got to be marching down Whitehall. You've got to protest in front of the Houses of Parliament and say, we want this, we want this. Time is now, time is now. That will change it. We cannot change it. Never mind the data. It's conflicts of interest and the stasis, the turgid way that government works.
Now, I can see hands going up, but there is a coffee break now. So can I just suggest that we do break for coffee? And we've got the rest of the day, and I'm sure these topics will come up. But I'll sorry about that. It's just otherwise 2 other hands are going up at the back.